Damn, kingzkidgram. Man, out to the RMO place. Let's get happy, my trusting you.
Hello everybody, welcome back to yet another video. Today I have another special guest for you today for our topic, is it really gone for good? We have a specialist prosthodontist in the room here with us today, and we're ready to be educated on the knowledge of teeth and is it really gone for good. Dr. Taruvingira, welcome to the platform.
My name is Dr. Alfred Taruvingira, and greetings to all viewers.
Yes, thank you so much for being a part of this, and we look forward to what you have in store to teach us today. So getting right into our video today, Dr. Taruvingira, today we're going to be talking about, is it really gone for good? So this topic is mainly based on patients, when they come in for an extraction, for example, for a tooth to be removed. They never really think about getting that tooth that was removed replaced. But could you tell us the importance of getting tooth replacements done after extractions, and what kind of replacements can be done?
Thank you. There are several reasons as to why we should replace missing teeth. And before I even talk about the need to replace, I think the mandate is on us, the clinicians, to educate our patients as to why they should have replacements. Because you see, the patient, when they come to you, all they want is to get rid of the pain.
Yeah.
In most cases, when they come to you, they'll have had an abscess or sleepless nights, and the last thing they want to talk about is replacing that pain. They would want it removed there and then. So it is that time when us clinicians are supposed to educate our patients as to what options are available as far as replacement is concerned. There are quite a number, from the removable and all the way up to the fixed options that can be used. And the reasons being that we need to restore function, and by function I mean there's a whole range of function, from chewing, smiling, talking, and all that stuff. So there is the need for us to replace in time so that things don't go wrong, because when a tooth is missing, there is a whole range of problems that we have, from speech to poor food selection. You won't be able to enjoy things that you used to enjoy, depending, of course, on the number of missing teeth.
Yes. So, Dr. Taruvingira, please do get into more detail for us. What are the specific types of tooth replacements available when one gets a tooth removed?
We have fixed replacement on the one end, and then we've got removable replacement on the one end. And when we talk fixed, these are replacements which mimic the natural. In other words, when the patient has them, they don't take them off. It stays in the mouth. And even within that fixed range, there is also another one which is called fixed removable, meaning much as it stays fixed throughout the day, or in most cases, there is a time when the patient can actually remove it. But when it's in place, it's quite fixed. And then in that section, we've got implant-supported prosthesis, which are usually fixed, and the patient doesn't take them out. It's as good as the natural tooth, and chewing and smiling and all that stuff is addressed by that thing because it's fixed. And then there's also crown and bridge work, whereby if there's a missing tooth in the center, like I can illustrate using this one here. Say there's a missing tooth here, there's a tooth there and there's a tooth there. So we can crown this tooth, or we can prepare it. By preparing, I mean you shave around it, shave around that one, and then take a mold. And when you take that mold, it goes to the laboratory, and they make prosthesis which is fixed. And this is one of them, which is a 3-pronged thing. And that one day goes onto there, and that goes onto there, and it's fixed. And of course, before putting it there, you put cement, and then you cement it home, and that's fixed. It's one way of replacing. And also, if you want to spare those, you can also do address the problem by just attending to the missing tooth, and that's an implant-supported prosthesis, where you surgically place the implant in that gap there, and when the implant is in place, you then secure a crown onto that implant, and the implant-supported crown can either be secured by a screw retain, or it can be cemented. Okay, and it's fixed. You don't take it out. And then there is also another option which you can fall it in the fixed range, where you can place several implants, and on those implants you put a bar to connect those implants, and on that bar you attach a denture which is fixed. That's when I was saying fixed removable, because when it's in, it's fixed, but the patient can actually unclip it and clean and do all sorts of things and then put it back. So that's like fixed removable. And then you've got the removable, which is more of the conventional stuff that most people might be familiar with. I often hear patients say, "Oh, I don't want those that are like my grandma, the ones that they put in a glass of water by the bedside." Those are the complete dentures which you can pop in, and then in the night we often encourage that they take them out. So they are removable. Okay, just to give the gums rest and to be able to clean. And there's a complete set of teeth for those with no teeth at all, and then there are partial removable dentures.
Okay, so we have been educated that you can get your tooth replaced when it is extracted, and there are several options available for you. Taruvingira, there are some dental students who are definitely watching this video. So could you please get into more detail for us on the step-by-step procedure to how some of these replacements are done?
That's quite a mouthful. There's a whole lot of stuff. I need about the whole day to explain. But just in summary, as we said earlier, we have the implant supported on the one end, which are the fixed means of replacing teeth, and we have the crown and bridge work, which is the conventional means of replacing teeth, as well as the removable. I can probably start off with the implant supported. I did mention earlier that with the implant supported, what we address is the gap where the tooth is now missing. And there are about three parts. The first part being the surgical phase, where we surgically place the implant into the jawbone. And when it talks out, meaning when it binds to the bone within a force parameter that is required according to literature, we can then put what we call a healing abutment on the day. By healing abutment, basically what we mean is like a cap that we screw on top of the implant, and then we stitch up the gum around that healing abutment. Basically, the other name is also a conformer. What we try and say here is it allows the gum to conform to a desired shape, which would need for us to place the prosthesis in the end. So that would be the first stage for the delayed protocol. There is another protocol whereby we can do it immediately, whereby when we place the implant surgically into the jawbone, we proceed to actually record an impression, which is taking a mold, which then goes to the laboratory, and the technician fabricates a crown, which comes, and then that crown can either be cemented or it can be screw retained on the day, and then we stitch up, and then the patient goes and walks out with a tooth, having surgically placed in the jawbone and secured the crown. Of course, there is a time frame in between, a couple of hours maybe, where the patient can wait for the jaw to come back from the lab. And then, of course, then off they go with the prosthesis. That's an immediate one. But often we go for the delayed one, delayed protocol, where the patient walks away with that conformer, which is a piece of silver metal, which is attached onto the head of the implant. And then when they come back for, say, maybe 10 days review or 2 weeks review, we cut off the stitches if they're still there, or if they've fallen out, all well and good. And then we take x-rays to see if our implant is still sitting okay, and if there is no inflammation. Once we're happy with those parameters, we then record the mold. It's basically the same sort of technique where we register the mold with either a stroke tray, which we modify to accommodate the implant, and the impression copy, which often comes sticking about the gum. And then that mold goes to the laboratory, and then we put back the healing abutment and we wait. When the crown comes back from the lab, the rest of the process is basically similar to what I said earlier about the immediate loading, where we can then collect the crown, remove the healing abutment from the tooth, and then secure the crown onto the implant. And then, of course, the patient goes. And then we then follow up, depending on the situation, maybe every 2 months, or every 3 months, or every 6 months. Maintenance is very key for that particular section. So that's an implant-supported means of replacing a tooth. The other way is to do the conventional crown and bridge. I did highlight earlier when I lifted this model, and I said when a tooth is say this is where the tooth was. The teeth, the neighboring teeth are like that, and there's a missing tooth. We anesthetize the patient, make sure it's nice and numb, because the idea is to shave the outer enamel and modify that tooth so that it's got the features that meet the preparation geometry that is required for a crown to fit onto the tooth. So we shave that tooth to end up with that sort of morphology. Okay, and then we record a mold, and then it goes to the lab. And in the meantime, what we normally do is we do a pre-prep mold, and using that mold, we can then make a temporary bridge. Okay, so basically, the patient walks out with, they can't walk out with these, of course, the way they are. One, they'll be very sensitive, and then the second thing is, if it's a bridge, for instance, we don't want these teeth drifting, because when we register a mold, this has to stay as it is for the prosthesis to fit. So that's the other function of the provision. And also during function, we don't want these teeth to be exposed to fractures and all sorts of damages that can happen as a result of chewing. So we want to preserve them as they are. So those are some of the benefits of temporization, which is putting provisional restorations on this. And then it goes to the lab, and then when it comes back, we remove the provisional restoration, and then we clean up the temps to make sure the cores of this teeth here, to make sure there's no residual cement and there's no defect of any kind. And then we take the bridge from the lab, and then we put some cement and we cement it off, like what I demonstrated earlier, and then it gets secured onto the patient, and then it's fixed. Then of course we give them oral health education as to how to maintain the prosthesis. Maintenance is very key as far as postoperative is concerned, because it adds on, not only does it contribute of course to good hygiene and having a fresh breath and being socially acceptable, but it adds on to the longevity of our prosthesis. So it's very important that on the day of the delivery, or even throughout the process from planning to the delivery, the patient needs to be informed as to how to maintain the prosthesis. And then the other one we mentioned is complete dentures. We can probably just chat about that. Complete dentures, there's another school of thought also which says, why not do the dentures in as short a visit as possible? So there is a school of thought which came up with a denture which can be delivered within 4 visits. So instead of doing all the 7 steps or 8 steps, you can actually manage to deliver. You squeeze in some appointments into maybe one. Let's say 1 visit, first visit, second, third. You do all those things in one, so that by the 4th visit, you can actually deliver the denture. So basically, not everyone is the same. So the trays that we have are called stock trays. So we can't use those stock trays for everything. It's an accurate measure of recording a mold. So we can register the primary mold with that, being a measurement of either the top or bottom jaw. Then we send it to the laboratory, and out comes a special tray. A special tray is like a custom-made tray, which is like this one here. It can only fit that particular patient if it's fabricated in such a way that it will register more detail. So using this tray, we test it in the mouth, and we modify it, wherever it's necessary, and then we put some impression in there, and we sit in the patient's mouth and record a more accurate impression. And using that mold, we then send to the lab, and they will make what we call a bite block or record blocks. These are made out of a material called wax, which is a very moldable material. And then using that wax, the bite blocks come back to us, and we register what we call a bite, or we generally call it jaw registration, which is a more appropriate term because we're registering how the top and bottom jaws come together. A bite block or record blocks. These are made out of a material called wax, which is a very moldable material. And then using that wax, the bite blocks come back to us, and we register what we call a bite, or we generally call it jaw registration, which is a more appropriate term because we're registering how the top and bottom jaws come together. And in that visit, we then select the shade and the shape of the teeth. In other words, the mold and the color of the teeth. With the patient, of course, we involve them so that they participate in the selection. And then we record all those features on the patient card, which goes to the laboratory. When that goes to the laboratory, they will set up the teeth according to the information that we provide. And then what comes back is what we call a trial denture. The teeth will be made out of acrylic as the final teeth, but they'll be set up in wax as the base on which they are set up. And then we try that in the patient's mouth on that visit, and then that is a very important visit because that's when we cross-check all the other things that we have done earlier and mark to see if we've made progress or if everything has been acceptable to the patient. And they get to weigh the dentures, what's base is there, but then they'll be more or less like the final product, and they can check to see if they're happy. If they're happy on that visit, then we send it back to the lab so that they can process it and finish it for the to be the definitive denture. But with the removable dentures, we often don't want them to stay for too long because the bone, as you know, it sort of shrinks with time. So those dentures at some point, they will need to be tweaked as well with the means which we call relining. It's basically to add another layer on the fitting surface so that they remain nice and intact. But even having said that, I mean, there are some patients who struggle with loose dentures, and there's a whole range of products on the market which the patients can use. Some are called denture fix, some are called polygrip, cookie dent, and all sorts of names. There's basically squirt a little material on the fitting surface of the denture, and then they pop in their dentures, and often it helps either during a meal or when they go out for the denture to stay in and not drop and cause all sorts of social embarrassment.
Wow. So we've just been given an in-depth knowledge by Dr. Taruvingira on the step-by-step procedures of how some of these replacements can be done. But we'd like to know a little bit more, Dr. Taruvingira. What are the advantages of the implants you talked about, the ones where you screw it in the bone versus the bridge where you were saying the tooth is prepped and then it's cemented on top? What's the advantage of one over the other?
Okay, thank you for that question. When we're looking at the fixed, the ones you mentioned are all falling in the category of fixed prosthesis. So when you're looking at an implant-supported prosthesis, the first advantage that comes to mind is the biological cost. Because what you're doing is you're only replacing the missing tooth. You don't touch the neighboring teeth. They remain where they are, and you're only focusing on the gap there, and you're driving the implant into the jawbone. And that spares the neighboring teeth. If anything goes wrong with that implant, be it maybe inflammation of the bone around it, or fracture of the implant for whatever reason, or some component within that implant supported prosthesis, one can attend to just that without disturbing the neighboring teeth. So that in itself is quite a good advantage because that saves or spares all the other teeth from any sort of harm. And also in terms of function, when it's just an implant, it's anchored in the bone. It's like it becomes almost part of the bone. There's bone that gets deposited around it, such that it's fixed, such that chewing is as near natural as possible. In fact, it can even be worse because it doesn't have a periodontal ligament, unlike the natural tooth. So one can chew onto a bolt without actually necessarily feeling pain. Because remember, there's a bouncing effect that comes from a natural tooth because our teeth tend to sort of displace. But whereas with an implant, it's fixed. So that's how good it is in terms of food selection. It gives the patient a wider range of food selection because it's as near natural as possible. But compared with the crown and bridge, of course, the main thing is the fact that you're only focusing on that gap, whereas with the bridge, you need more than at least 2 teeth for you to make a bridge because you're bridging the gap. So in bridging the gap, you end up cutting, sometimes very sound enamel. And apart from that, should there be a problem as well with the one anchor of the bridge, you end up removing the whole bridge just to attend to the problem. Unlike with the implant where I said you only attend to that missing tooth there. So those are some of the advantages of having an implant versus a bridge. But you do get some patients who also say they don't want anything surgical, they don't want the invasive nature of an implant. But we do have more than 30 years of data now to support that. Implants are predictable, they're successful, and they can actually they're serving their profession very well, actually, as far as restoring function is concerned. The other problem, of course, with the crown and bridge, I did mention recurrent caries or secondary caries. They are cemented. The crown and bridge is cemented onto the tooth, and you know how it is in function. You can't sort of control some sort of mobility that can happen in there, or cross-brushing techniques which lead to dissolution of the cement which holds that bridge. As long as there is dissolution of that cement, one is bound to end up with secondary decay. And when the secondary decay, the core again or the anchor of that bridge can be destroyed. And yes, we can take a series of x-rays during recall visits, but it's not always easy to pick up that decay. And one can carry on with life not knowing that the core that's holding his bridge or his or her bridge is actually being destroyed. And when they then present to us, often it's too late to salvage that bridge, and they end up losing it. But implants are also, they also come with their challenges as far as maintenance is concerned. One needs to be very meticulous with their hygiene. But having said that, I did say that we draw out a plan, a follow-up plan for every patient, so that we can assist with the maintenance of these processes.
One thing that people fear, Dr. Taruvingira, as well when it comes to getting a tooth replaced after extraction is the thought of an implant, as you were describing, having something screwed in your bone. It does sound a bit much to the layman watching, but could you kindly just reassure the general public watching this video on how safe some of these tooth replacement options are? Yeah.
Thank you again for that. Yeah, well, it's only normal, I think, for people to be concerned about these things, because it's something that's going to be in their body, hopefully permanently, and they'll want to know the long-term effects of that. But, we now have almost 40 plus years of data as far as implant supported prostheses are concerned, or implantology. In fact, much more than that. As way back as 1969, I think, that's when we started sort of playing around with the implants and stuff, thanks to the late Professor Branham with the implant system that they invented. And it has evolved over time, and now I think we are very comfortable with the data that we have and with the way the implants are performing within our profession. So there's really no need to worry as far as the side effect or toxicity and dangers are concerned. For starters, I mean, the material that we generally use for implants nowadays is titanium, which is quite inert, and some are surface and nice, some are not, but there's really no interaction with the body itself for one to worry that maybe if I'm to have this metal screw in my bone, it will probably either corrode my bone or send some cancerous stuff into my body. No, we haven't actually come across that. They are very safe, and like I said, we've got quite a number of years of that, almost 40 years plus of data to support that. And there are patients walking around with these who are being followed up, and there's been no complaints as far as that is concerned. In fact, what they should be concerned about is to practice very good hygiene, which we should do anyway, even if you have natural teeth. We all have to. More so when you have this foreign body where you don't want to expose it to oral microorganisms, which would then lead to it being rejected by your body. So they are very safe, and they should not actually be concerned. As you know, the mechanism of the body when it comes to infection is such that it always wants to get rid of that which is infecting it. So in the same vein, when you place an implant and when one sort of practices poor hygiene, those microorganisms that harbor around the implant are the targets by the mechanism of our body to get rid of that infection. So it's not so much the implant itself that's causing any sort of poison to your body, but it's the microorganisms that we are allowing to stay by either practicing poor hygiene or not having regular checkups and stuff. So as long as they maintain good hygiene and regular checkups, they'll be fairly safe. So there's really no need to worry. And as for crown and bridge work, I mean, it's been around since time immemorial where dentistry evolved. And also with maintenance, one can actually have those prostheses for as many years as possible. And where there is a need, they can also be replaced along the line, especially crown and bridge. They can be, when there's leakage around the margins of those crowns, one can actually consider having them replaced so that you spare your teeth from further harm. So in terms of replacing missing teeth, I don't think patients or people out there should be worried that they're introducing some toxic substances in their body.
Oh, great. So you heard it from the specialist himself. These replacement options are completely safe. What the main issue is maintaining them and making sure that you clean and have good oral hygiene when you get replacement options after extraction. So moving right along, Dr. Taruvingira, there is this option of surgical correction before replacement option. How important is this, for example, before dentures, getting pre-prosthetic surgery done? Could you just explain that to us? And also getting everything else sorted out in your mouth before getting a replacement done. How important is that?
Very good question. Because you see, what's the point of actually prescribing a prosthesis that the patient would not even bother to wear? And it's quite, I wouldn't say depressing, but it makes one sad to actually go through all that work, and then when your patient walks in, they're walking with a denture in a bag. You know, so in order for one to make a denture that will be predictable in terms of the patient wearing it, it's always good to make sure that the platform on which the dentures are gonna sit, it's comfortable. It doesn't have any protrudences or any features that would hinder the use of that denture. So hence you mentioning pre-prosthetic, meaning before we make a prosthesis, what should we take care of in the patient's mouth? So what comes to mind, little bony spicules that can occur as a result of normal healing. You know, following an extraction, if one just does a random extraction and in a very rough manner, the remaining bone which was surrounding that tooth can heal but in a very jagged manner. And whatever gum is on top of that will also conform to that jaggedness. And when one wears a removable denture, for instance, there is no other way besides that denture having to sit on that jagged sort of foundation. Now you can imagine that thin piece of gum being trapped between the acrylic denture, which is hard, and the bone, which is underneath and jagged. Obviously the patient will not wear the denture, they'll always complain. And on top of that, trying to chew some with that denture. So pre-prosthetic surgery would come very handy because one would anesthetize the patient, make sure it's nice and numb, and then use all sorts of instruments or drills to burnish that jagged bone underneath and then re-switch it. Wait for healing, and when the patient heals and the gums are nice and smooth, you can then start taking the measurements to fabricate prosthesis. And that way I think it will be more predictable that the patient is most likely going to use the prosthesis without much drama. That's in general. And then the other features for pre-prosthetic surgery are to do with aesthetics. There are certain, gum lines. Some people are generally have a very gummy smile. In other words, they show too much gum. Or some are a very thin gum biotype. We call it a gingival biotype, meaning the nature or the thinness or the thickness of their gum. It tends to be very thin, such that if you go ahead and place an implant in that patient, there are certain things that can, compromise the aesthetics. Maybe the implant can actually show through their gum. So one would need to do some pre-prosthetic stuff in order to correct things like that, which would hinder the aesthetics of the prosthesis. By aesthetics, I mean the way the prosthesis looks in terms of when someone looks, how pleasant it appeals to the person who's looking at it or the patient themselves. It has to be very pleasing in terms of the outlook. The other one is flabby gum. The gum can be very flabby, especially for patients who've had missing teeth for quite a long time. They can end up chewing on that gum, and amongst those who chew against gum, tooth against gum, some actually the bone becomes quite robust underneath and the gum follows and becomes also very tough, what we call keratinized, being very nice and tough. So those ones are fairly okay, but there's another range of patients where the gum then becomes very loose and mobile. And to make a denture, especially a removable one, which will sit on moving gum, I'm sure you can imagine how that denture is going to be when the patient is trying to bite or just putting it, keeping it in. It becomes difficult because it's sitting on mobile tissue. So there are instances when one can recommend that that gum be trimmed so that there's less of that mobile tissue before we start taking measurements for us to fabricate the prosthesis.
Wow, so you have heard that there are good reasons in getting a full dental checkup first to see if there are any issues that need to be addressed before you get any tooth replaced in your mouth. So for the dental students watching this, Dr. Taruvingira, you did mention that it is important to take a good impression, an impression when doing some of these replacement options after extraction. So could you just go through with us some of the different impression techniques one can use as a student and even as a practicing dentist when doing some of these replacements in clinic?
There's a whole range of impression techniques depending on what it is that you want to do. If we're doing fixed, or removable, nowadays it's either we do the conventional impressions where we mix the material and then use what we call a tray, which is basically a measuring tool which carries that mold, which carries that impression material into the patient's mouth and helps to mold some form of a template of that mouth. And that's the conventional one. And nowadays, there's the digital one. I know it's the way we're going. There, as far as some sort of measurements are concerned, but we're not fully there in terms of digital scanning replacing the conventional impression. But that's another form of recording impressions, where you use an intraoral scanner after doing everything else the way we described, cutting the preparation of the tooth, and then all you simply do is to use a digital scanner to scan the tooth that you have prepared. And then out comes the image on the computer. And then using that image, you can either do your milling of the crown, do 3D printing of the crown, or whatever else that you want to fabricate, but using just digital. And when it comes to the conventional impressions, we do have, as I mentioned earlier, the stroke trays, which are trays which are just there. We have small, medium, and large, and which hopefully would fit everyone somewhat, depending on where you fall, as far as the shape of your mouth is concerned. And then using that as to record what we call a primary impression, we can then fabricate what we call a custom-made tray, which obviously would fit that particular patient's mouth. And the material of choice is just acrylic, and with that one you can either have a spaced tray, meaning there's a bit of space. You use a wax spacer when you make that tray so that there is space, which becomes the room for our material, which records the mold that we need to fabricate whatever it is that we want to make. Or you can have a closed one, depending again on what impression that you take. And then in terms of technique, remember I mentioned again about the flabby ridges where the gum is mobile. It depends again on the impression material that you're using. For that, when one has a very flabby or very loose gum, you can't use a material which is what we call mucocompressive, meaning it's thick and it tends to displace tissue. Because if you record the mold using just that material, whatever impression, whatever image that you get, it will falsify the information that you then use to make the prosthesis, because the tissues would have been displaced by that material. So you need a special tray made, a custom tray made, and we often use what's called a window tray, where you cut off part of the material and leave it open. And you record the impression with any other material using the rest of the tray, but in that window, you then paint the material, the impression material, so that you record that flabby or loose gum with what we call a mucostatic impression material. Basically what it means, it's a material that is runny, it's soft and it doesn't displace tissue, it tends to just follow without pushing the gum. So that's the one we choose, and you paint layer by layer until you fill up the tray, and then you do, it's almost like a two-stage type of impression technique, where you register the rest of the firm gum with a conventional impression material in the rest of the tray, And there by the window, you paint layer by layer, and then you do a pickup of that impression, so that that loose gum is not pushed, it's not recorded under function or under load. Basically, you don't squeeze it. You just let it stay where it is, so that the denture that you make in the end or the prosthesis comes and it fits to conform with the tissues at rest. They don't have to be pushed. So that's another impression technique. And also, I mean, when I say technique, it just depends on the scenario really that you're dealing with as to what sort of technique that you need to use to record the impression. And the other one that comes to mind as well is maxillofacial prosthetics. Basically, that one we're talking about patients who had maybe a tumor that could affect maybe the top jaw or the bottom jaw. They then go to the maxillofacial surgeon, they get the tumor excised or cut off from the jawbone, leaving the healthy part of the bone. And often that leaves a very huge defect following removal of that tumor. Those patients come to us and we have to make a prosthesis. We have to give them teeth. Yes, they are relieved the tumor is gone, but they have to have teeth there. There are impression techniques as well that you have to employ in order to come up with a replacement option that restores function for such a patient. There's a surgical way of correcting the defect. Yes, they can put like a fibular graft followed with tissue grafting and all that stuff to fill up or to reduce the depth or the severity of the defect. But ultimately, they would need teeth, and to record those molds again, we use special trays or custom trays, and we have to employ all sorts of techniques to register an impression of the defect. There's what's called a molar impression, which is basically layer by layer, and then eventually you put layers by layers of different materials which record the defect until you can then get all the pieces together, and then you do almost like a jigsaw puzzle where you connect all those pieces, and then you can make a prosthesis either using silicone or all sorts of other materials that you can use in order to restore or repair that defect with the teeth. And for the dentures, of course, it's the same acrylic that we tend to use. But the base itself, it might have a silicone base, which is a soft base. And for you to have that record, you need a whole range of other sort of techniques that you need to employ to register that impression. So it depends on the need. There's maxillofacial prosthetics, which needs what I just said, and then common bridge work, implantology, and conventional dentures. And for dentures, as you might know, they are sort of two sets of materials. There are those which are called mucocompressive, where you want to displace as much gum as possible and register that mold and make a custom-made tray. When you have that tray, there's really no need for that mucocompressive material which pushes the gum. You need some very flowy materials which can use as little as possible, because that tray fits quite nicely, so you don't need like a whole kilo of material to fill up the tray. Even the position that you stand in, the position you keep your patient is also key. And even the way you mix, if you're mixing by hand, for the upper jaw, for instance, you obviously don't want to use a material that's very runny and stuff, because it might go down the throat if the patient is seated in a different position, in an awkward position, and you end up choking the patient. So for the upper jaw, you might want to make something that's more a thicker mix, so that it doesn't float to the back of the mouth. If it's the lower jaw, it's more forgiving because of gravity, everything just goes down there, so you can make it a bit runny. So when you say techniques, we're looking at all those things as well. You have to consider all that stuff to decide on which techniques to use and when. So it depends on the situation that you're dealing with and what material you choose, what type of tray you choose.
So as we round up the video, Dr. Taruvingira, we'd like to just hear from you if there's anything else that the general public or anyone watching this video would like to know or that you'd like to add concerning replacement options of teeth and just the importance of getting a tooth replaced, and that it doesn't have to be really gone for good.
Absolutely, it doesn't have to be gone for good, because I mean, there's a common saying that you often hear people saying, the best medicine for a tooth is one should not always be quick to just getting improved. There are so many other, ways of keeping our teeth. If it's so, for instance, endodontics, which is root canal treatment, is one way of actually relieving you of the pain. You are in pain, you come to the dentist, I'm in pain, please take it out. Be sort of receptive and then take their advice. If they are saying you can save your tooth by means of root canal treatment, they can relieve you of the pain by doing that procedure, and you get to keep your tooth. And by the way, much as we have all these fancy means of replacement, nothing really beats your natural tooth. Your natural tooth is what you need to look after. So if they say they can do root canal treatment and save it, by all means embrace it. Okay. If it then fails later on, then yes, of course, we can come up with these replacement options. So it starts from there, where pain should not be the driver when it comes to making these decisions, which often are very drastic. Because I'm seeing patients who come to me saying, I was never given the choice. I was just told you can have it removed without any reference whatsoever as to what it is that you can use to replace those missing. So, no. I mean, it shouldn't be gone for good. When it's gone, make a plan to replace. And generally, I know replacement can be very expensive, especially when it comes to the fixed options. It can be very expensive. So once one is busy working and able-bodied and stuff, that's the time to actually consider having it replaced. Okay, then at least you can carry on with maintenance. And once the maintenance protocol is within your system, even when you're older, I think some of these things become sort of second nature to you. Than for you to start learning how to use interdental floss and when your hands are shaking and stuff. So I often encourage patients to consider replacing pretty early, because I mean the other thing that you might also know is the teeth tend to drift, and that causes a whole sort of issues.
Wow, Dr. Taruvingira, we cannot thank you enough. Thank you so much for just sharing with us today, just educating us on the importance of having tooth replacements done. You mentioned so many issues that come with gaps in our mouth, the drifting of teeth, your diet is compromised, you can't eat the way you're supposed to. So a tooth doesn't really have to be gone for good, because there's so many replacement options available. So thank you so much for watching this video today. I hope it encourages someone to definitely get any gaps that they might have filled, or to get any replacements done if they need replacements. Thank you for watching, and see you in the next video.
I put my trust in you, cause you give me comfort. You know the man that you should like.